Debbie and Phil. Debbie presented in December of 2020, 2021, I think. And Phil presented in March of 2023 on their ongoing project in St. Louis, in Missouri. And so I'm going to they're both dear friends of mine, friends and colleagues, and I'm going to turn it over to them to lead the presentation and discussion for today.
Sure, we'd be happy to. Debbie, go ahead.
Yeah, and I would just jump in and say that the previous presentations were actually on some EHE supplements that we were working on. And this is a different project that we're really excited to be doing in partnership with Robert Heimer. And Phil is actually going to be leading the presentation today. And so I'm going to turn it over to Phil, who's at the Washington University in St. Louis. Go ahead, Phil.
Thank you so much. And I want to also mention that Katie Wang is also on this. She's outstanding, has helped us with this project as well at Yale. So so a lot of familiar people have shaped this project. So if at any time you have trouble hearing me, please just interrupt because I won't be able to tell. So as I'm going, if you have any trouble hearing, please speak up. So today we're going to talk about our first manuscript off of an R21 project in the qualitative part of a mixed methods project. So we've been working with quantitative data, but now we're approaching the qualitative data. And so we want to present this in its earlier stages so that we can get some feedback about the framework we're using and the conceptual understanding of diffusion of innovation specifically. So this will give us an opportunity to kind of bounce some ideas. This is an earlier stage of a project. This is not, well, I wouldn't say earlier stage of a manuscript from a project. So, so that's the results that we're going to be presenting today are going to be preliminary quotes and findings within this conceptual model that that we would like to get some feedback on. So, okay, before I get too ahead of myself, today, basically we're going to cover a bit of a background, an overview of our project, and then applying the diffusion of innovation framework to understanding adoption of medication for opioid use disorders and harm reduction in rural Missouri, and creating a conceptual framework for understanding rural adoption, which is just kind of emerging in research now. But introduction, this is our research team for our project. It was an interdisciplinary project across WashU and Yale, specifically Yale School of Public Health and CIRA. I'm an assistant professor at the Brown School at Washington University. I did my postdoc, and Dr. Heimer was my mentor for that process. I worked with Lauretta as well while I was here for a year, and then I came to WashU. And we, when I arrived to WashU, my research interests look at scaling up evidence-based practices for the treatment of opioid use disorders and harm reduction in areas where resources are constrained. Specifically, my area of focus has been in the criminal legal system, but recently has moved into more rural settings. And in rural Missouri is unique because it has a disproportionate prevalence of HIV compared to other rural areas. And this is what has essentially brought Missouri into the Ending the HIV Epidemic Initiative. I'm not going to go too much into it, but for the just for the Ending the HIV Epidemic, Missouri is one of 7 states that were selected for a high rural prevalence of HIV. This happens within a larger context of a long history of high rates of rural drug use. You know, if we remember about 20 years ago, 10 years ago, Missouri was like #1 for methamphetamine use, specifically through smoking, but also injection. Now that is actually both fentanyl and methamphetamine and other stimulants being used. So those rates are still quite high, but now there is an opioid epidemic or crisis that is overlaid on top of that. It's characterized by very high rates of injection drug use and a high prevalence of HCV, particularly among people who inject drugs. This also occurs within a larger context of low rates of PrEP implementation and more reluctance to implement innovations in harm reduction in rural settings in Missouri. So this kind of convergence of issues creates a syndemic of HIV, HCV, and overdose in rural Missouri. And so why is this important? Well, syndemics share common drivers, and this includes kind of shortages in harm reduction resources, shortages in treatment access. The co-occurrence of these issues work together to worsen the outcomes of HIV, HCV, and overdose. And we know little about the rural issues that are affecting these drivers. Many of the studies that have been published have been focused much more on the urban context and suburban context, but not the rural context. And by rural, we mean very rural, like fewer than 500 people per square mile. This is a very rural setting. And in Missouri, every single county in Missouri except for 2 is rural. Every single county except for 2. Depends on how you classify it, but Missouri is a predominantly rural state with 2 major urban centers. Columbia and Greene County, which is where AIDS Project to the Ozarks is also a suburban kind of setting, but really a very rural area. So what do we think about before we move forward? I just want to kind of create a kind of common understanding of what we think about as innovations in harm reduction. And because we're going to talk a lot about this concept of diffusion of innovation. And innovation in the context of harm reduction is the development of new strategies that overcome barriers to access, overdose prevention, or other methods to mitigate the harms of drug use. And the creation of novel strategies can also be thought of as methods of increasing the uptake and diffusion. So in and of itself, not necessarily an innovation in the intervention, but it can be an innovation in the engagement strategy. What I mean by that is like mobile treatment or telehealth. So it can also be, an innovation can also be a mechanism by which we make it easier to access care. This can also be fentanyl test strips, low barrier, low threshold MOUD. And so what we're finding is that there's this rapid development of these innovations, but little is being done to understand the factors that predict the implementation of them, especially in rural Missouri. So just to very briefly talk about what is diffusion of innovation. I'm assuming everybody kind of has an understanding of this, but this explains how adoption of an innovation spreads from a concentrated few to the general population. So how is it that a strategy that is used by few becomes adopted in the mainstream? And this can be by either providers as potential implementers or community members as potential implementers. So if we think about layperson administration of naloxone, that's an example of potential adopters who are part of the general population. But then we can also think about adopters who are providers. And so we're going to talk about both today, because we're talking about community implementation, implementation of harm reduction at a community level. And so thinking about this is important from both a community and a provider level. And much of our work is really stuck at the provider level, not thinking about community acceptance of these issues. And this is an issue that we're trying to kind of touch on with this. So there are important questions to think about when we're looking at developing an understanding of rural diffusion of MOUD and comprehensive harm reduction strategies. First is, what factors influence providers' decisions to adopt MOUD and harm reduction? What factors influence members of the general population decision to adopt harm reduction? And what role and this was the purpose of our larger grant, what role do intersecting stigmas play in shaping, sorry, I keep clicking on the screen, play in shaping decisions to adopt harm reduction and MOUD among potential adopters in rural Missouri? So recently, there was a pulling together of multiple drivers of adoption. And I think this is a useful framework for thinking about. This is actually out of systems engineering. This is really yet to be brought into public health in this way. But I think this is a useful framework for approaching diffusion of innovation. perceived attributes of the innovation has been used a lot. This is Rogers from like 1962, like from, 60, 50 years ago, the work that was done looking at relative advantage, compatibility, complexity, trialability. This was all done within the context of technological adoption. So adopting internet or adopting computers. But there has been much work done in the engineering space to expand on that. And this article provides I think, an interesting roadmap for harm reduction to be thinking about kind of creating a multi-level framework for understanding diffusion of innovation. So at one level, we have perceived attributes of innovations, which can be at the community member level or the provider level. We also have the type of innovation decision, which could be optional, collective. Is this mandated? Is this required? Is this done by an authority? So, for example, we can think about buprenorphine and all the policies that were around buprenorphine and mandating it and thinking about waiver requirements and how that's been lifted. The other piece is communication channels. How is this information communicated? And we heard this a lot in this study about messaging. How is harm reduction messaged? And so I thought this was a very important piece that's very relevant to the work we had been doing. And then there's the nature of the social system. This is the social environment within which the innovation is occurring. And then the final layer is the extent of change agents' promotion efforts. So what are important early adopters or change agents doing to promote the success? And this can be through coalition building. This can be through public messaging as well, but led specifically by members of the community who can be thought of as change agents. So leading up to this study, this was back in 2022, we convened meetings of key stakeholders individually and in a full group to kind of do some stakeholder engaged research. We discussed ideas about why providers were unwilling or reluctant to implement harm reduction in rural Missouri. And we received significant buy-in to this project, and we submitted an R21, got funded, and the overarching objective of that project was to investigate the impact of intersecting stigmas on attitudes towards adoption and prescribing behavior, essentially, among providers working in rural FQHCs and HRSA health centers in Missouri. But a very important part of that was to conduct in-depth interviews to get a more detailed, contextualized understanding of the individual, provider, clinic, community, and policy level influences over community adoption and provider adoption of harm reduction. In the end, we ended up, through the amazing work of Debbie and Robert on the ground working with us to collect this massive amount of data, we ended up collecting data from 17 providers, 18 people living with HIV, several community advocates, and regional leaders. And in rural areas, it is tough to recruit people. So that is just one thing to think about from a qualitative standpoint, that we have found it is difficult, but through very, very persistent recruitment strategies, like at conferences and at provider association meetings, we were able to recruit people to participate. So specifically, our qualitative data collection aimed to generate qualitative insights into multi-level social contextual factors that shape provider adoption and prescriber practices. And in so doing, we surveyed both people living with people with lived experience. We define that as people either living with HIV or people who have had a opioid use disorder diagnosis. Our key aims there were to measure experiences with accessing a MOUD, attitudes, and experiences with intersecting stigmas. At the provider level, we looked at perceived attributes of MOUD and harm reduction interventions, determinants of implementation, relative advantage, attitudes towards MOUD and harm reduction, definitions of harm reduction, norms, values, and cultures and social climate. And then we looked at community advocates and regional leaders. And here we looked at public attitudes towards harm reduction and stigma to gain deeper insights into impact of changes in buprenorphine waiver regulations, syringe exchange, telehealth, peer support, to get a sense of the larger context within which provider adoption was occurring in rural Missouri. So we did outreach. I'm not going to go too much into this, but we did outreach through visits to agencies, clinics, nonprofit organizations. So for those of you, I don't know how many people were at our presentation 2 years ago or when we did this, or a year and a half ago, but we hadn't done this yet. So this is kind of like an update from like what we did when we last spoke. We were planning all of this activity, and then it rolled out shortly after. And so we did outreach through visits to agencies, clinics, nonprofit organizations, community events in 7 counties to introduce the study and recruit. We did tabling and screening on REDCap. We had to give a pretty sizable incentive. Um, and this is just a spread. If you're familiar with where the Ozarks are located, that's predominantly where the sampling occurred. From the Ozarks generally stretch from the green, that little county on the little white dot on the very far east is St. Louis City. What surrounds that in green is St. Louis County, but the blue that go down is all the Ozark mountain range. So that's like where the Ozarks start and goes all the way down. So a disproportionate number of our participants were representing views and perspectives from the Ozark region of Missouri. And I mention that because it's a very independent area. It's a very unique area, and it has a long history of substance use problems and harms of drug use over decades of stimulant use and alcohol use. So just to give a little bit of a background there. So what we hope to do, we went into this study not with this perspective. We went into this study with the perspective of perceived attributes, and we measured these, but this framework had not really been published yet when we went into this. So, but we did measure a lot of these things throughout our data collection efforts. So when I saw this framework, and we're just to step back for a moment, we're looking at within this larger project a paper manuscript that is the first manuscript to look at within our project, to look at creating a conceptual understanding for the diffusion of innovation in rural Missouri that uses a multi-level perspective. And so what I've done for this paper is gone through all of our results and started the process of coding and within some of these classifications. So going into the data and mapping out what am I learning about these different groupings from the data. And there's a lot in the data that touches on this. And let's see here. So within the first, so we're going to switch to results and talk a little bit about what my preliminary assessments of the data has revealed going through kind of some of these initial codes. And one of the most important pieces, and Debbie did an amazing job kind of formulating this and answering this at APHA, was just looking at how do rural folks define harm reduction. Thinking about this from the perceived attributes, what are the attributes of harm reduction broadly? And we found that this multi-level or provider kind of perspective here kind of gives some of the strategies that were identified, and some of them are naloxone distribution, syringe services, contact hotlines, contraception, fentanyl test strips, MOUD, basic needs like housing, support and therapeutic and peer groups, very specific like wound care and STI testing and PrEP. This revealed that a lot of the providers, community members, people with lived experiences, they have a pretty clear understanding of what harm reduction is. And I think this is important because I think a lot of people kind of assume that in rural areas, people don't know about these options. People don't really know about what's available. But going through the data, there's a decent amount of knowledge. And this isn't generalizable. This is, again, just from the providers that we spoke to. But the recognition, for example, that harm reduction goes beyond just providing life-saving care. It includes employment. It includes teaching coping skills. It includes not just only having abstinence, but approaching abstinence or working towards those goals, or also not working towards abstinence. But it was much more complicated than this when we looked at this more. Um, what we found was some very interesting understandings of the necessity of harm reduction and how it would fit within the community. Um, I found some of these quotes pretty interesting about the perceptions of the necessity of harm reduction, particularly where the EMS and ambulance takes over an hour to arrive. In many of these areas, you cannot rely on the emergency medical system to get there in time to render life-saving care. And when we had people describing, for example, that you have to have four-wheel drive or ATVs to get to the places where people are overdosing. And so these attributes are very different than what you would see in an urban area. Also, I thought this was really interesting because people are talking a lot about stocking vending machines and putting syringe exchange and having resources placed in the public health departments. And there's a lot of resistance about that, reluctance about that, because there's an understanding that the community has such stigma that everybody knows each other. And by putting these things in the front lobby, it's going to identify and out people in this space where people are wanting to have privacy. That issue of privacy will come up again shortly. So here it's also where, thinking about this, I thought this was very interesting, where people don't necessarily think that harm reduction is relevant to them until they experience someone in active addiction, that it takes lived experience to kind of accept it, to be, this notion that once it touches your personal life, or losing your son or losing somebody in your life, that you will see the benefits. This came up multiple times. The other thing that came up is the rate of change just being very slow in these areas. But there was a general wish to have more programs available and more acceptable, and that there was a great necessity for these interventions. So what I thought was also very interesting was that this idea of like whether or not these services should be mandated. This came up a bunch of times. When I was reading through both the matrices that were used to analyze the data, which I didn't include that for time purposes, but I'd be happy. Debbie's on the call and who created a lot of the matrices for the data analysis, and she can answer some of those questions. But what came up when I was reviewing the themes from the initial data analysis and the codes that were coming up was many folks mentioned maybe people aren't going to change until we're forced to, as part of, for example, becoming an FQHC. FQHCs have comprehensive services, prevention. That's a big piece of FQHCs. FQHCs are required to have numerous prevention strategies. And so requiring harm reduction may be an effective strategy to scale up at a rapid rate. Also, the constraints of risk departments and liabilities came up a lot, having to operate within the thresholds of our legal liability, for example, around syringe exchange or around or syringe services, which are still not legal in the state, but many people are providing in a gray area here. So that gets into these state guidelines, murky waters that can be very, very difficult. Also, policies that are both mandating or preventing implementation. Medicaid did not cover PrEP. So people mentioning that these barriers around policies that can actually prevent implementation because a lot of these services are just not covered. And so can we get more of these prevention services covered by Medicaid? And as that being an influencer of innovation decision among providers. So pivoting to communication channels, there is a wealth of information here. This could probably be its own paper, but I think it's a very important conversation to have within this rural context. Many folks mention that community education is the most important way to kind of change people's perspectives by doing these community outreach events, town halls, where doctors and medical providers with legislators, for example, are meeting with people in the community. And also, upon receiving a program, spreading word of it into the community and being mindful that it's not spreading misinformation. This was a very important piece that came out as well. we saw a lot around community training around naloxone. Naloxone training for potential community adopters really was viewed by providers as their responsibility. We heard that come up, or going through the data, I heard that come up a lot. And then the other part that I thought was really interesting was this last piece around care to not promote misinformation or stigma by the team. And I think, you know, this one quote talking about how they met with the CEO and some people from their admin to really talk about and to get people that are really truly qualified to be able to squash stigma and make sure that there's not misinformation around, for example, overly emphasizing abstinence, overly emphasizing behavioral, for example, as opposed to medication treatment. These are old methods, older, like dated strategies. And so this definitely came out. And this, just so you know, I wanted to clarify this. When you see PROV, that's provider. CMAD is community member advocate. And the regional leaders is RL. And I'll clarify the next one if I see it. I know I'm leaving one out, but I'll spell that out when we get to it. The other piece here is, what is the proper pace of education in rural areas? This is another real communication issue that came up where, and I thought, you know, it's like with these rural areas, you're really going to have to like feed them the information slow. It's like it's all going to start with education about substance use disorder as a whole. And it's going to be you know, people need to get comfortable with it and seeing it. So here we're seeing both observability, we're seeing kind of like a need to sit with it and be able to have the space to be able to process this before they're making decisions around adoption. And so, yeah. Yeah. So pace was very, very important. Thinking about nature of the social system, a very common theme that came up was that rural areas have smaller social networks with, you know, this impossibility of going anywhere without running into somebody you know. This has been known and studied about in the HIV literature, where why is it that somebody might travel 2.5 hours to get HIV care instead of their local community? And it could very well be a personal choice around not wanting to be in an area where, especially like a community pharmacy where everybody in the local pharmacy goes. So we have a good amount of research in that. And we saw that kind of come through in the substance use space quite a bit. And, you know, also the other piece is reputation. This idea of the more rural areas, reputation is just like, or how people view your family, came about a lot. And so if you have a negative reputation, you're almost like doomed from the start in a local community. Like, for example, if you have a parent in recovery, a parent who's a substance use person, or, which is unbelievable that happens, a sibling who might have passed from substance use, and then now that person is also using. This piece here, you know, it was mentioned a lot about how the intimacy of a rural area being a double-edged sword, that it impacts your ability to provide for both yourself and your family because of the fact that reputation can be exclusionary in many rural areas. We had a quote that I didn't include before, but it was somebody talking about how they can't go to their church anymore because of this factor, because of the reputation and being in recovery. And so it came about even with people who are in lived experience, and we were hearing that. Also, this notion that routine behaviors among rural providers are very hard to change, which slows progress and adoption. One person said, you know, it's such a pain in the ass to get providers to even engage in a warm handoff. And you can't tell them to do anything different than what they've already been used to doing. And one of the things that came about is this implementation decision-making around whether or not it should be a compelled decision, or, you know, whether or not these should be required services or not, because of how slow the rate of change can be, particularly in rural areas. So perceptions of being judged by the system.
Uh-oh, can somebody, do you have Debbie, do you have a way to text him that he seems to be muted at this point or something.
Yep, just a minute.
Okay. I don't know if he can see the chat even, so.
It seems he left the call for now, hopefully rejoining very shortly.
Yep. And I have texted him. I can certainly, looking at where we were, I can jump in, but I also don't want,
Is anybody receiving any message from Phil?
I have not gotten any message,
Nor have I, but I'll give
but
him
why don't you give him a call, Robert?
yeah.
And I can go ahead, let me put it into presenter mode. And jump in, okay.
We often try to solve technical problems before the meeting starts, but unfortunately they can happen during a meeting.
Exactly, that. Do you have him, Robert?
He's not answering his phone, and his voicemail mailbox is full.
Okay, so
Take it away, Debbie.
Yeah.
we trust that Pete is watching, and when Phil gets back into the waiting room, he'll pop in.
I'll look for it.
Okay, great. So as Phil was noting, one of the challenges is this deep concern about being judged, and the way that internalized anticipation keeps people even out of serving, even out of accessing services. This next piece is sort of a bigger piece. There we see Phil coming back in.
Go
Phil,
ahead. Yeah, go right ahead. Sorry, you can finish what you're saying.
well, I was just going to say, so I'm still with the nature of the social system, and I'm happy to finish this slide and then give it back to you.
Sure.
But that challenge of once you're perceived as a drug addict, that's how you're treated even by the system. And the challenge of watching the system not serve people because they're labeled, put in that box, and then a wider set of needs are not addressed.
Yep.
Phil,
Yep.
can you see my slides?
Yeah, that's great. If you want to keep them up, that might help me not lose the call. It's funny because like right as clockwork, it started sleeting and then I lost you. So it's
Yep.
funny how that happens.
So there
I
you
didn't
go.
pick it up. Yeah. So, okay. So that's great. So in the final area that we kind of code, or that has been coding out some of the data around, is this idea that the extent to which change agents promote the efforts of implementation, promote the efforts of innovation being scaled up and adopted. And so at this level, one piece that came up was, well, why is it that change agents might not promote this? And I thought there was an interesting quote that was kind of emblematic of one piece here, and that's, it's not until someone of importance dies, a child, a loved one, that they see the importance of these life-saving measures. And in other words, somebody that resembles their population, someone that resembles them. And so this is true across populations, that people tend to be affected more when they see people they identify with passing or affected by these issues. But this did come up. The other piece that came up were grassroots coalitions being formed kind of across key stakeholder groups that were informal, but then held public information sessions in local communities. So one person noted that they pulled together a task force, an informal task force with the police chief, and having at least a couple meetings with minutes and agendas, and police seeing this increase in overdose being present there also were helpful. And noted that there were about 80 people, which are pretty large numbers for rural areas. And so keeping up to speed with these grassroots coalitions is extremely important. And this is something that is being done, nationally with harm reduction. Anybody have anything to add, Debbie or Robert, around that? Around that piece? Robert collected some of the data for this as well. So.
Yeah, a little bit. No, I think the work probably raises more questions than it answers.
Mhm.
This is often the
Yeah.
case. It doesn't really address the issue of how to build coalitions between these disparate groups.
Yeah.
It doesn't really address the issue, and I think this is the last point you sort of talked about, is how to get communities that are so riddled with drug use to stop thinking of drug users as the other.
Yep.
And as
Yep.
part of their community.
Yep. That's a very important question. And it's kind of a good segue to asking the group some questions. Because we had, so just wrapping that piece up. Thank you, Robert, for that. And I would just say that we are collecting more data. I mean, we're analyzing more data. This is our initial mapping out of this conceptual understanding. Very rough draft. In fact, it's the first time Robert's seeing it. That's how rough it is. So, this is kind of an initial mapping out of how we can organize these different domains around a meaningful structure and to kind of inform future intervention. And so synthesis is ongoing, and we're using findings from each domain to hopefully design an intervention to be delivered in these rural settings. So there, Debbie, you can now advance this to, I just had a couple of broad questions really about what are our thoughts around this framework, and what are the challenges or feedback that might come to mind in using this perspective in this rural setting? And then what might be some ideas around maybe assessing the nature of the social system and the extent of change agents promotion efforts from our prior work? What are some like resources that could be used to better understand those pieces? Because that's where we have the least amount of research on. That's what Robert ended by asking that question. That's what we know the least about. So what kind of information should we be considering in that process? And any other questions, obviously, are welcome. Or thoughts. And that's it. Right at the time I thought, quarter of.
I want to encourage people either to just speak out and, I don't like to monopolize the discussion period. So speak out, or if you feel more comfortable putting a question in the chat or a comment in the chat, that is also perfectly fine. And we can, get it out there for you. One thing that I will just kind of, because I'm always prepared to make at least one comment to begin with and let people think about what they want to say. One thing that really comes out for me is if there's a larger message that I'm taking away from this study, which is a very fascinating study, is it recalls a quote from Harry Stack Sullivan, who some of you may know. He was a psychoanalyst back in the early 20th century. And he said, all of us are much more human than otherwise. For be we happy and successful, contented and detached, miserable and mentally disordered, or whatever.
Mhm.
And the thing that really hit me between the eyes were two things that you said. That when you said something about the behaviors being hard to change, getting people to adopt, that's human.
It is.
That is all of us, whether we, reside in a highly urban area or a highly rural area. That is an essential quality of being human. People do not like to change. The other thing on the pace of adoption that I kind of thought about was, I think oftentimes we put a lot of weight on education. And I just always kind of want to caution that education certainly is necessary, but
Mhm.
it is not sufficient.
Oh, yeah.
Whatever kind of education is needed. And that's where you get into, well, to get your intervention implemented, what kind of education is needed?
Yeah.
A question I wanted to ask was the whole thing about stigma, because the stigma and confidentiality and the reticence to get care, locally, these are again very human things that I've seen in many other parts of the
Very
world.
true.
So I was wondering what your thoughts were about how to promote decreasing stigma. Did you have any thoughts about that?
Interestingly, this kind of ties back. I've had a couple of like very skeptical conversations with program officers at NIDA about their views on stigma, which was kind of funny. Where I spoke to somebody at NIDA, and I don't want to say who it was because it was kind of funny, because she said, do you really think we could change stigma? Like, do you really think that it's actually possible to like do these interventions? Because we're not seeing a lot that actually works. And I responded, Robert, I think this will ring true to a lot of what we saw with the quantitative data, that providers were most likely to adopt, for example, buprenorphine prescribing when they actually viewed it benefiting their job. And so, all right, so we have two kind of issues here. We have one about, does it benefit their work? And then the other issue is, does it improve the quality of experience of the patient? And so these can be two interrelated issues, but they can be different also, in the sense that changing stigma among a provider might get them to adopt it, but they may, and excuse my language, still treat their patients like shit. They may do it because they think it's making their job easier, but they may be conveying a message that is degrading, demeaning, or dehumanizing. And so I think that's where it gets very complicated, because you can promote adoption without addressing stigma, and that may not be the best solution. And so I think to change stigma, you have to kind of get specific about what you're trying to change. If you're trying to change a provider's behavior that is stigmatizing, it may require a slightly different approach than changing the perceived experiences, or at least recognizing that these are two issues that kind of have to be addressed.
And I also want to speak
Go ahead.
to this because one of the stories we heard in one of these interviews was about how the Missouri Cooperative Extension was asked by the father of someone who had died of an overdose what they were doing as the cooperative extension about substance use. And they're like, well, I guess we're not really doing anything. And said, well, what are you doing? And so they actually developed a recovery-friendly workplace initiative that they are taking to chambers of commerce throughout Missouri.
Mhm.
And they have gotten national attention for it. And
Yeah.
I have told all kinds of people about it, because
Wonderful.
that's not addressing stigma directly, but it
Mhm.
is addressing it indirectly
Yeah.
by saying, for economic reasons, this is who lives in your community. If you're looking for good employees and you can change your workplace to be more supportive, you have this whole new set of resources, and we're never going to be able to deal with addiction if we don't make it possible for people in recovery to get jobs. And so that, I have to say, is like my poster child of examples of creative ways of addressing stigma.
It's going to whatever is the target audience's need.
Yep.
You know, if it's going to make my job easier, is it going to give me a bit more staff? That is
Yeah.
brilliant.
Right.
And certainly, you know, must have been done in different ways around the nation. My feeling also is, you know, with the stigma issue, yes, stigma is really an important issue for sure. But there is so far you can go, because if there's that anticipated stigma in the person, it will, you know, it will, there's nothing you can do by intervening at the provider level. Luke, you wanted to say something.
Yeah, Phil,
Right.
thanks for the presentation. I've heard so many nice things from you about from Debbie about you, and it's great to hear about your work. I really like the way you described the diffusion of innovations. I mean, for those that aren't aware, this is really kind of the intellectual precursor to consolidated framework for implementation research, which I think is one of the most common usually used tools, you know, in qualitative analysis for implementation science or just implementation science in general. But my question relates to kind of strategies for addressing the stigma and other factors that you identified. I have a big interest in my work, which is mostly international and in peer navigation. There's a lot of literature about this in the HIV literature. I don't know as much about it for substance use, but in my own experience as a clinician early in my career, when I was in training, I worked in a community that had extraordinarily high levels of injection drug use, and we almost every single day would have multiple patients that would be taken care of who would have complications of that. And I remember one of the most powerful things for me was, you know, a person who was in recovery who spent time with us to try to explain some of the things that frustrated us in terms of caring for those individuals. We used a lot of buprenorphine actually, and that was just very powerful in building empathy and developing strategies, I think, for approaching those individuals with respect, but also kind of understanding like what would be some productive things. So peer navigation, what do we know about that? Is that something that you're considering in that setting?
Yeah, I'm gonna just say something, and then I know Debbie, with her work in CHWs, will have a lot to say about this as well. And Robert, also please chime in, because you collected the data and you probably saw some of this arise as well. And it's great to meet you as well. And I think, you know, what we want to have is a permeable, flexible relationship between people with lived experiences and people delivering interventions. I think whatever we can do to create more of those feedback loops through both having peer navigators that have lived experience, that's like an amazing way to bridge the two, but it can be much more than that as well. And I think having workforce development that is focused on navigation throughout the system as a major part of like customer service. Like if you're thinking about an FQHC and you're thinking about these places as kind of businesses in some respect as well, the front facing aspect of that is patient satisfaction. And if we could be really grounded about what we mean by that, that's like, sure, this person could be at death's door injecting drugs, but they're still a patient. They're still paying, they're still coming and receiving services, and we want to give them services, and they should be treated as a person that is going to be getting the best quality care. And and so sometimes the word customer can be a loaded statement, but I mean more like a someone who is utilizing a system designed for them that should have quality of care at the forefront of that. Peer navigation, I think, is like one of the most important QI, quality assurance kind of strategies to, if we're thinking about this simply from a more kind of business oriented approach, I think that can help us sometimes, where we say, well, what's going to be most beneficial, where it's going to be somebody greeting them at the door that looks like them, that has some sort of identification with that person. And so I think peer navigators really do kind of address that desperate, you know, very vital need of FQHCs to help people navigate the system. what I will add, and this is something I'm sure that Debbie can speak to, is systems navigation is really important. I think a lot of peer navigators navigate within one system, but where I think the biggest challenges we see with peer navigation is helping people get through like the housing system, the the employment system, these like multiple things that can be very difficult to manage. So whatever we can do to broaden that, I think is very, very helpful. Yeah.
And I would just, oh, go ahead, Lauretta.
There are interventions where I mean, I think, Luke, what you bring up is a powerful intervention where if you have the provider or the staff person doing a shared task of some sort with somebody from whatever target population you're working with, that can do a lot to diffuse preconceptions about, in this case, what it means to be HIV positive, what it means to be an injection drug user, what it means to be a drug user, all those things there are interventions like that to try to work through and in that work process, change attitudes about another group. In this case, the HIV and the injection drug use. I wanted to ask a question about fentanyl. How pervasive is fentanyl because from where I sit, injection drug use is not the risk these days.
Not as much
Yeah.
in rural areas, not as much,
Yeah.
but fentanyl is predominant.
It is what does predominant mean? 51% or 95%?
I don't know that. I mean, I would say it is the most common. I mean, you can get this on the Missouri Department of Health's website, but it is, I would say, the most commonly by a long shot, like 75% or more.
Yeah. Yeah.
Of what? 75% of the overdose
Opioid.
deaths?
Of opioid opioid involved deaths, and probably even more so of the overall.
Yeah, I would think so too. I wasn't confining it only to deaths, Robert, but
and drug supply as well.
Yeah, absolutely. So, okay, all right, because I think that has maybe something to do with the injection risk, but that's neither here nor there.
And I want to make one comment about peer navigation that since Luke raised this, and that is that peer navigators need just having lived experiences is often not enough, and in fact can be counterproductive if they bring to their navigation the belief that their way of solving their drug use problem is the only way.
Yeah.
That there are multiple paths to overcoming addiction. Some of it is through abstinence, some of it is through medication, some of it requires religiosity or encourages religiosity, and some doesn't. And if people are stuck to a single pathway as their navigation, just think about going down the highway and you're stuck in traffic. Sometimes it's better to get off and try a different route.
Well, I think that you're hitting on two things that are near and dear to my heart. Harm reduction is that there's a flexibility, that you meet the person where they're at, and you let them have autonomy in deciding how they want to progress in their life. But beyond that, the other soapbox for me in probably attacking not only the issue of peer navigation, but also of stigma is communication skills. That communication skills is really, and it's not just how do you say what, but it's the whole of communicating. What is your body saying? What is your mouth saying? It's all those things all together that everybody needs to who's going to be working with a sector of the population needs to understand and implement within themselves.
Mhm. Yeah.
Adati was, I was just seeing you nodding so much.
Hmm.
Again, it's a necessary skill, but it's not sufficient.
Absolutely. We're
Well,
right up
this-
on time. Sorry,
Yeah.
Laura.
Yes, no, I was gonna say, this brings us to the top of the hour. Thank you so
Thank you.
much. This was a wonderful presentation. We'd love to hear
Excellent.
more about, how you ultimately decide to, I don't know if we were very helpful in giving you other suggestions to frameworks or ways to organize the data, but come back.
Well, it's lovely to see everybody in one room. It's been a while, Loretta. Thank you. And it's good to meet everybody and network with new faces and get a chance. I hope to see you all again soon.
Absolutely. Happy holidays to everyone.
You as
Yes.
well.
Take care. Bye,
Take
everyone.
care.
And
Bye-bye.
Karen,